Hello, welcome. Thank you for being here today for the Sight and Sound Bites webinar. As you might know, I'm Carrie Fogel. I'm the Senior Director of Development for Foundation Relations here at the Eye Foundation. And we have these webinars every month in different topics related to vision loss, hearing loss, head and neck cancer, sinus allergy, balance disorders, and conditions of the voice. So today's presentation will feature a discussion about rehabilitation of patients who have or have had head and neck cancer with our Division Chief, Dr. Matthew Spector. So as a reminder, we don't use the chat function, but we will do a Q&A session at the following the end of the presentation. So I ask that you submit your questions into the Q&A box at the bottom of your screen at any point during the presentation, and we'll hold them all till the end. Anything that's unanswered during the Q&A, especially if it's like personal in nature, we will send those questions directly to Dr. Spector and his team, and those answers will be sent to you via email. And as always, there will be a video of today's discussion available on the Eye Foundation website. So before we get started, it's my pleasure to introduce Dr. Matthew Spector. Dr. Spector is the Division Chief of Head and Neck Surgical Oncology and Microvascular Reconstruction, and the Director of the Head and Neck Surgical Oncology and Microvascular Reconstruction Fellowship. He's also a professor in the Department of Otolaryngology-Head and Neck Surgery. Dr. Spector specializes in all aspects of extirpative head and neck surgical oncology and head and neck reconstruction. His research interests relate to both clinical and translational questions in head and neck oncology and head and neck reconstruction. His primary interests lie in improving the overall survival of patients with head and neck cancer through outcomes research to improve patient selection and prediction of response to therapy. So we're thrilled to have him. I don't think I can necessarily call him new anymore, though he's been here a little over a year, but we're thrilled to have another webinar session with Dr. Spector. So I will turn it over to you.
Thanks, Carrie. Okay, well, welcome. Thanks for taking your lunch hour to spend some time to hear about a very important topic to me. There's a very nice introduction, but what I really have two main parts of my research. One is to make cancer cures better, right? So whether it be a genetic test or a surgical technique. And then the other part is the rehabilitation, right? What is your life like after cancer? And that's an equally important part. And that's actually why one of the main reasons why I came to the University of Pittsburgh and UPMC was to try to kind of build out the reconstructive or rehabilitation practice. I got lucky when I came here. There's such a great program already. So I had to, move the little few pieces around, but all the parts were there and we're continuing to build. This talk, again, is talking about rehabilitation, but I kind of wanted some specific examples of rehabilitation. So as we go through, I'll talk about it. A little bit of rehabilitation starts even before we have surgery or you even undergo any treatment. It's really talking about kind of the parts that we're using to rebuild things. So I'll talk a little bit about free flaps and basics and things. And I have some similar slides I did before, but I want to make sure that's the starting context of all this. And then we talk about those considerations and what a patient might want out of a reconstruction. And then finally, I want to actually talk about specifically some nerve rehabilitations, because that's kind of the newer areas that we're going and some of this nerve work that we're doing. So obviously we can recreate kind of soft tissue and shapes and tongues, but getting the nerves to work again is a huge part of rehabilitation. So we'll end with that. This first part we'll go through a little quickly. I have lots of pictures, so if you're not a picture person, and some of them may consider questionable or gross, but that it's all going to be okay, and we'll move through the slides fairly quickly for some of those pictures. The main part of where rehabilitation begins is reconstruction with another part of the body. So again, my primary goal with the beginning of rehab is taking a piece of skin, fat, muscle, bone. The most common one was actually from the forearm. It's one of the first ones ever described, a part of the arm. You harvest the artery and vein, and this is a microscopic picture where we hook up the new artery underneath a microscope, hook up a new vein underneath the microscope, And then, it's a living, breathing part of you again. Here's what one of those might look like. And so this is a gentleman I treated back in 2013 or 14. You can see that we take the skin and fat from the arm. You see some labeling on here, right? So this is the dorsal part of the tongue. FOM is flora mouth. So I was going to rebuild a little bit of the tongue and the flora mouth. You can see here, we took the artery and vein. This is the kind of on the back table. You hook up the new artery and vein in the neck. So kind of a gross picture, but here's those blood vessels coming down, and we open up the carotid artery and jugular vein. We hook up the new vessels, and then you might get something that looks like this. And so this is 6 months after surgery. You can see that the tongue looks kind of normal. You see there's new skin of the mouth, but this person eats a normal diet. You see no kind of teeth on the bottom here, but again, that's a bit of a different question. But in terms of our functional outcome, this is a good outcome. And so, rehab starts in the beginning. The reason we're getting better at this is because if you look back in 1976, this was done out of the University of Michigan before my time there, but I was trained by some of these people, including Dr. Baker. Their first free flap took all 4 of these surgeons, and it took 24 hours. And it's kind of like that old phone that you used to have or carry around. Nowadays, we all could wear an Apple Watch. If you like Apple Watches, they take 4 to 8 hours of surgery, and so the recovery is quicker. You don't have all that anesthetic time, and then we do these as team-based surgery. And so this was a huge part of my recruitment here and how I think that this surgery should be performed. If you looked at my specialty, 50% of surgeons stopped doing the reconstruction part because it was too tiresome. And so, one of the things I looked at is, this was a study we published, last year or end of last year, looked at, if we did these in teams. So if you meet me in clinic, you're going to meet another one of my partners, Dr. Contrera, Dr. Schritterin, and you're going to see them too, because if we do this as a team approach, your overall operating time is lower. And then your overall fluid shifts. So the amount of fluid you need to support you intraoperatively, that causes you to have a longer recovery, right? So we give you fluid while we're doing surgery to keep your blood pressure up, but it can cause problems afterward. You can get very swollen. Your lungs can get full of fluid. And so it decreases complications. So anyway, the purpose of the slide is to say at UPMC, we're using team-based approaches, and this has really helped show we have better outcomes. When I meet with patients in the clinic, we really have a lot of things to talk about. And so, one of the first things is this is all the places of descriptions of flaps of different parts that I've taken or you can be taken. This is the year they were first described. These have been advanced, of course, but there's a lot of different choices for people. And so that becomes the first question. And so, what are we reconstructing? Is it a tongue? Is it a jaw? Is it facial skin that you need a good color match on? What do you need to do that? What's the tissue type? Do you need a thicker skin or a thinner skin, right? Think about the thinness of the skin, maybe around your forehead and your eyes, and maybe thicker on your cheeks or maybe part of your neck. This could be different for every individual. And then, of course, we have to figure out, what can we use and what can't we use? One big thing I've found for people are tattoos. So I meet a lot of patients that have a very important tattoo to them for their life and for their family, and it means a lot. And so that may exclude or include a site that I might be able to use. And it's something, I typically spend some time to talk to people about. So I have this same slide I use for fellows because I teach the fellows as well. And when I go over this and I ask them, well, what do you want to do? I get a lot of looks like this. And so a fellow, when you're trying to teach them, you need to be able for them to make the decisions in the next few years as they go out from training from the University of Pittsburgh. But it can be a tough thing to do. And when I get this response, I always say the same thing. You just have to talk to your patients. And so figuring out occupation and hobbies, exercise preferences, again, tattoos and scars, are you left-handed or right-handed? And just kind of seeing what people like to do. And you can't always ask, what are your hobbies? Because a lot of times people say, I have cancer, it's hard for me to do anything right now. I want to know, where you're going or what you want to do in the future or what you were doing that you want to do again. And so those are definitely questions that we need to ask. And once you get a sense of the person and what their kind of expectations are, I can give you the expectations on my side of what we need to do to make the job done. And then we can start to talk about, what things will look like. So after we've picked a site and after we figure out where we're going, we have a rehabilitation team. And so this is sometimes the hardest thing to explain because, you have your expectations around surgery, which is very scary, but then there's always the rehab that's done afterward. Part of the issue is I think we don't do a good job of talking about it. Like if you've ever had a hip done or a knee done, sometimes you go to physical therapy before you've had the surgery and they spell out everything that you're going to need to do. We've started to institute a little bit of that pre-visit, but those pre-visits are, we don't always know what we're going to find or how things are going to work out. So there's a little bit of gray area when we do them, but, afterward, our rehabilitation team really takes over. And that's where I got super lucky when I, coming here a year ago to UPMC, working with Dr. Nielsen and Dr. Johnson. So those are the two in the middle of the picture here. They run our survivorship clinic. And so this is really a comprehensive evaluation. And so once we do the best reconstruction we possibly can do, once we get all the pieces of the puzzle together, just like you get a new hip and you have a great implant in there and your incisions are healed, how do you get that hip functioning the best way forward? And that's by using it and figuring out, what the limitations are and how to push those. So in this clinic, you meet a lot of people. You meet our speech and language team. You meet our physical and occupational therapists. You can meet a nutritionist. You really have a comprehensive evaluation. The impressive thing for me about this is the networking that happens, because I know, I love it that, I work in Pittsburgh and live in Pittsburgh, but many of you don't. And so we need to make sure that you have those support resources in the community. And so we've tried to, Marcy's really branched out and trying to make this happen at other sites. So, the main hub might be Pittsburgh, but how can we kind of spread our care, throughout, Southwest Pennsylvania, Ohio, West Virginia, to reach more people. If I could pick one of these things, and I think again, hip surgeons will say the same thing, it's typically the physical therapy around it, especially around when we pick sites. And so, if I have someone who wants to golf again after surgery and we're using a part of the arm or the leg, the best thing we can do is start rehab on that site right away. And so I personally feel that physical therapy for some of these sites right away. And I think a lot of it is, I think people are scared to try to use these, the donor sites or this, after surgery. And so working on range of motion, working on foot balance, working on the thigh kind of, balance and weakness, we can start almost right away. So we want incisions to heal, but we get going good. You can do it for 3 months. It's not something forever. Again, it's a lot like a hip. You get it going, and then once you've done it and figured it out, you get going pretty quickly. I put a couple of examples in here. I mean, we have tons and tons and tons of handouts. And so, we have lots of resources for patients to start these quickly. It could be as simple as you're watching TV at night with your family and you're using a squeeze ball, or we have these little kind of things you hook to your feet while you can be sitting on a couch, leaning back and just kind of working your feet around. So it can be, depending on what your needs are, we can really tailor that. I would say we recommend physical therapy to about 90% of people, but we get about a 50% hit rate on what happens. And maybe that's okay. I mean, maybe if you're getting better on your own, maybe we don't need to intervene on these things, but these types of resources are where I found people make the most gains after this. Another issue that can happen is every person's a little bit different. So I have some funny pictures here. And so these are kind of the variability of outcomes. And so, part of my pre-counseling of people is maybe this is going to be your scar afterward. And how do I describe that? And how are we going to rehabilitate an arm or a hand versus an upper arm scar that you might have? Sometimes I do the same surgery on the same person. Like these two gentlemen had the exact same surgery. Like down to the T, I can tell you like the dictations are perfect, the size, the shape of things. And you can see the gentleman on the right has a hard time getting that arm up. They're both 1 year out in this picture. So they both had a big jaw reconstruction. So they look pretty darn good. So it's hard to, that site has healed up really well. But the gentleman on the right's like, yeah, I can't go hunting anymore because this arm it's hard for me to pull a bow back. And whereas, this gentleman has no issues with it, even though they had the same surgery. They both had rehab too. And so some of that variability makes it a little difficult to predict, but we're trying to standardize the approach for all these. I have a couple more pictures just because I like to really focus on the functional outcome. Same thing. This gentleman had the same surgery for jaw reconstruction. This young woman also had the same surgery for jaw reconstruction. She's a little less far out, but again, the same thing has happened, that she's got good function of her arm even at 6 weeks after surgery. The other thing that can happen is I can't always predict how things heal. And so this gentleman was a police officer. And so we had to take bone and skin from the leg to rebuild part of the jaw. And it was hard for him to go back to work because he does a lot of walking, right? He had like a walking path that he did. He used to walk about 3 miles every evening. And this took a little longer to heal, and I can't always predict that. It ends up healing, but again, some of that is it's something I have to kind of counsel people on. So, the kind of the point of rehab is, it's unbelievably important. We can't always predict it, but almost always you get better over time, and sticking to the plan can really help. We're going to switch a little bit of gears here, as I want to talk about nerves. And nerves has been something that has been probably underrepresented in head and neck reconstruction. I think part of it is surgeries used to take so long just to get people to, take out the cancers and rebuild things. If that takes, 12 to, 18 hours, it's very hard to spend time to kind of tweak everything to make it kind of perfect. There's other things you have to worry about. You have to worry about the heart, the lungs, fluid shifts after surgery, how, going to the ICU sick on a ventilator. Nowadays with a 4 or 6 hour surgery, patients wake up and are sitting in a chair in the afternoon after surgery. And we can really spend a lot more time thinking, how to optimize some of these reconstructions. And my personal feeling is that nerve reconstruction has been underrepresented in head and neck reconstruction. And that I think we're going to see a lot more of that in the future. And I hope patients start to bring these things up. I'll give you one example from the other like body sites. Like breast reconstruction has undergone incredible growth over the past 10 years. And so they do the same thing. They can take skin and fat to rebuild breast tissue for women after breast cancer surgery. But now they're starting to do neuroptation. And so before it would be, you wouldn't have any sensation. It was again, you couldn't feel it. It was all numb. But now they're starting to sew nerves in to that tissue to get them to regenerate. So you actually have feeling there. And that, to me, when I saw things like that over the past few years, I knew that I would be able to find similar things with head and neck reconstruction. So I have two examples of those things. I want to talk about facial nerve or parotid reconstruction. So tumors of the cheek in the gland here can involve the nerve to the face. And I have an example of how nerve reconstruction helps with that and kind of how I think about that reconstruction. And then tongue reconstruction. So if we take out part of the tongue, you can lose sensation of that area, you lose taste, and how, over the years I've thought about tongue reconstruction and how nerves are going to be really important there. So parotid reconstruction. So, every time we think about surgery, there's kind of the principles of surgery that we go around. So you might have a cancer principle. A lot of these are easy, right? It's like removing the cancer, making sure the margins are negative, sampling lymph nodes, trying to hide incisions as best as possible. Reconstructive surgeons think about it the same way. So when I see a patient who needs parotid reconstruction, whether it be for cancer or trauma or whatever it is, the first things first is I want to kind of have a symmetry of the face. And so I want to make sure patients are able to move their eye, they're able to blink, they're able to swallow and speak. The volume has to look good. So even if everything works, if you have a big dent, that's no good. And then there has to be a color match, right? So if I'm resurfacing skin and the color doesn't look right, it's going to look like a patch and it's not going to be right either. And I'll show you how I've thought examples of that. Here's an example of a young woman of had a cancer of the parotid gland. And you can see a couple of things, right? So you see there's a droop on this side. So a lot of people think it's been a stroke, but if the nerve has cancer in it, you'll get a droop on this side. She can't breathe through her nose very well. See the nostril? So the nostril gets pushed over, and then you can't blink. So the eye actually blinks with the nerve. And so this is her trying to blink and the eye stays open. And so that is not a good, obviously, result to be able to live like this. And I can hopefully help rehabilitate this. So, what has been published on this before I came? This was a study out of Michigan that they published right before I got there. You can see this is a gentleman who had a parotid reconstruction. So this is new skin of the parotid. And, for the longest time, people were taking a piece of the arm and using that as the best piece of skin. That could be a big scar on the arm. You can have some issues with the hand there. And so while it's one reconstruction, one of the first things I was thinking is, well, what is the best one? And so I designed a small study to figure that out. So we looked at 276 patients that had, that had imaging throughout their body. And so one of the questions is where's the best piece of skin to take? Like if you came to my office and said, okay, I need a parotid reconstruction, where's the best part to take from each person? And so we measured this in 276 people. We measured the volume of the gland per person. We measured the different thicknesses of all the sites. And we found a number of different kind of good sites for this, the best being maybe from the back. And so this is called a periscapular flap. And that to me can be one of the best. So if I can ever hide an incision on someone's kind of armpit crease or back or underneath clothes, I really like that a lot better. It's a lot better than having a big scar on the arm or having a big cut on the leg. And again, as you talk to people, you'll find out, these scars do bother them. And so the study showed that, again, the y-axis here is the best match. So 0 is the best, right? So it means they're the perfect match. And then on the positive numbers are the thicknesses is too much on one side, and the negative numbers, it's too thin on one side. And so the periscapular flap did really well for this. Here's a different graphical representation in men and women. And so in women particularly, we found that that periscapular flap proportion was actually higher, whereas men had a little bit smaller chance of having a match in the periscapular flap, but had other sites that we could use there too. And so maybe this is different by gender, maybe it's different by BMI or weight. And so it's something that, as patients come in, I talk to them about. And then this is what it looks like in actual patients. So this represents 8 patients, the last 8 patients I did reconstructions on for parotid glands or have been reconstructed for parotid glands. And you can see the normal represents this other side. So we're measuring the volume of the other side, and we wanted to match it to the volume of the reconstruction side. And you can see these are all pretty darn close, except for one patient. We were able to match that side pretty good. And so that tells me that the volume with periscapular flaps does a pretty good job. And then here's what it looks like. And so this is a woman who I treated, this is about 5 years ago, with a parotid cancer. The tumor was involving the skin of the parotid gland. And this is a piece of skin from her shoulder or back here. And so the scar hides very well, and you can see that the volume match is pretty darn good. I had a fellow, Alan Fang, he works out of Mass at Harvard right now, but he was a fellow about 4 years ago who was very interested in color matching in patients. And so, having a really good color match can almost be more important than volume matching. So if I'm thinking about rebuilding something on the cheek or the neck, we really want to try to get that color the same, because, as your eyes track when you look at somebody, you may look at their, eyes first, or their mouth or their nose, but if there's a color difference, usually people can tell pretty quickly. And so this is a really cool graphic art software we use. So we took, about 130 pictures of patients, and we put it into the software program, and it would tell me how close of a match I made with the color. And so here's how that software works. So this is one of my first surgeries I did. This was back in 2013. And this is a skin from the arm, actually. And so what the software does is it partitions the colors. So you can see how this color match has been partitioned to the closest match. And then it does the same thing with different spots along the skin. And you get graphs that look like this. And so on the x-axis, you can see all the different flap sites. This is the thigh. This is the lower leg or fibula. This is a part of the lower back. This is a radial forearm from the arm. This is that parascapular flap that we like so much. And then the lower the average, the better the match. So you want to have the smallest number here possible. So you see the three lowest numbers are flaps from the calf. This is the medial sural or calf flap, the arm, and then the back. And so this gave me two data points saying, okay, parascapular flap may be good for volume. So when I counsel the next person that comes in my office, I could say, okay, here's the data, and here's how, as we try to figure out the best choice for you and what your rehab is going to look like, here's where we should pick up front to give you the best outcome. We looked over time as well. And so if you look over time, the colors get better over time in all flaps, which is really, really nice. But you can see parascapular flaps, lateral arm flaps, and MSAPs can hold up over time. And then here's what those look like. And so on the left picture here, you have a picture of a thigh. So this is what the thigh flap looks like. You see, we're usually paler in our legs than we are in our upper extremities. And so you can see the color match there versus this is a parascapular flap. And so you can see kind of, this is pretty fresh from surgery. This is only about 8 weeks, but you can see the color match is pretty darn good. I have a gross picture coming up again. This is our index patient that we wanted to talk about with the nerve stuff, and I'm going to get into the nerves here. This was a very large tumor that extended around the ear and into the cheek, into the parotid gland that caused that nerve damage. Here are those initial pictures I showed you. We have to remove this tumor. So this is us asleep. So we're going to end up removing all of this. These are gross pictures of surgery again. And so again, this is if you don't want to look, probably now's the time not to look. This is what it looks like after we get everything out. So we clear all the margins. We meticulously work to save arteries and veins and as many kind of things as we can. Here, the nerve was already out. So we have to do nerve grafting. And so there was a point where people weren't getting nerve grafting. And so it was not being done. In this case, I did 2 different types of nerve grafting. So these yellow represent the branches of the nerve that she still had. The blue and the red represent little grafts that I put in. So I can harvest grafts from different parts of her body. I can harvest grafts. There's actually a cadaver graft that you can use that can work for this called allografting. And you can use those grafts and you hook them up, and they take a while to work. And so here's what the hookup looks like. Again, another gross picture coming. So you can see here, like this right here is a new nerve that I put in. So there's a new nerve here, and there's a new nerve here. And so those are kind of nerves that had to be cut from the surgery. You can see there's a big area we have to refill in here. And so I took a piece from the leg to rebuild this. This is too big for one of the parascapular flaps to take, so we had to use a different site. Here's what it looks like after surgery. Again, it's a pretty good outcome, but the losing the ear is always a tough thing, and we can do that later down the road. We can put in kind of bone anchored implants to put the ear back on, but we really have to get through treatment and get everything to heal first. And then here's the nerve, and so you can see she can move her face again, and so that's a really good result. This is about 6 months after surgery. I'm going to play a short video to show you what this looks like. A big smile there for me. Good. You're gonna relax completely. And there's kind of a small smile. Perfect. And then close your eyes all the way for me. Good. And then open your head. And one more big smile. Good. Okay. And how long ago? And so you can see she's got a lot of excursion here. And so remember, this nerve was paralyzed after, before I even met her. And then in about 6 months, we can get some really good kind of movement here. You saw the eye closes again. And so it's not perfect by any means. Like you saw, there's a little bit of kind of twitching that happens in the cheek, but this is a good result for her. And just by taking the time to put in those nerve grafts. And so again, as I counsel people, there's different strengths and weaknesses of different sites, but as we go forward, I think these are things that I try to express to my patients. Okay, here's the benefits of this, and here's the downside of this, and then we can kind of pick which is going to be the best thing for them. I'll give you one more example, and I think we'll still have some time for questions here. The tongue is a very similar thing, and so tongue cancer is typically related to smoking and alcohol. It can be from small spots in the mouth. Usually your dentist is checking these. We're always happy to see you if you're worried about a spot. Very few spots in the mouth are cancer. So if you look at a white spot in your cheek or your mouth or your tongue or your lip, over your lifetime, it's only about a 10% chance of turning to cancer. And so it's actually pretty low. So as long as we catch them pretty early, we do very well with those, but it's as they maybe a pre-cancer that turns into a cancer that becomes problematic. The same thing goes with reconstructing a tongue, right? You want your tongue to be able to touch the top of your teeth so you can make the T sound. You want to be able to obliterate the volume. What that means is your tongue has to fill your mouth, because when you swallow, it pushes everything down, goes to the roof of your mouth, and it pushes everything back. So without that obliteration, it's hard to swallow. Your tongue acts like a finger, right? Like if you have something stuck in your cheek, right, you're able to clean those things out. So you want to try to have that mobility. It's really important. And then again, you want to be able to you don't want to drool. That sounds obvious, but secretion management. So your tongue acts as kind of a pump to keep things going back so stuff doesn't come out. And then we want to keep everything sensate. And so again, out of all these, I listed sensation last because we used to think of it as, well, as sensation, all these other things might be more important, but how does sensation matter? What can we do with nerves of the tongue to help your tongue rehabilitate? So what does this look like? And so this is a paper, it got published about 2 years ago. And this was what I wanted to hope to show, that if I took the time to hook up the nerves to the tongue, we could get a better functional outcome. And so patients would be, reporting they can swallow better, speak better, eat better, something that's important to make sure we're able to do. And so we're able to do this. And so this was published in the last few years. We were able to show this. And I'll show you what that data looks like. What a lot of us don't realize is that there's a lot of tongue branches and nerves. So the nerve of the tongue is this one right here. This is the lingual nerve. And it comes down, it sends all these little branches. That's why I use this diagram, because all these little things are nerve branches into your tongue, right? Not just sensation, but taste, deep pressure, hot, cold. There's a lot of things that does. And so, how is that going to be important? I assembled a cohort of patients. There were 84 patients that we looked at. We had the neurotized group, which is the group that I hooked up the nerve, and then we had a control group. Usually these were patients that did not have the nerve hooked up. It could have been a different surgeon that did it. Maybe there wasn't a nerve to hook up in that case, but we had about 40 patients in each group to compare them. I show this picture just to say that they were about the same groups, and they're looking like there wasn't more tumors in one group than the other for any reason. And it turns out it works. And so, I asked patients questions. And so that's one of the things, as you design rehabilitative studies, you're trying to do reconstruction, you have to ask the right question. If you ask somebody, how are you eating? They'll say, okay, or fine, or good, or things are okay. What is your diet? But if you ask people, what type of solid foods do you eat? Are they kind of mixed materials? Can you have any consistency of solid food? That's when you start to get into the details. And so you want to be at the bars you want are going to be in all the way to the right here. And the neurotized group did extremely well. So they're able to take, oral intake without any need for feeding tubes. The range of liquids was excellent, right? Almost all of them could drink almost any liquid that in any consistency at any speed. And then range of solids, we also saw that the groups are doing really, really well. Same thing with speech understandability. And so, when you go up to somebody at a store, how often do you have to repeat yourself? Or, do you feel like when you're on the phone and someone calls you that you know or don't know, we call those trained and untrained listeners. I'm considered a trained listener because I'm used to hearing different speech patterns. But if you go up to a random person that calls you in a store, how well can they understand you? And that, in neurotizing the flaps, that makes it better for patients. And then again, this, I wanted to repeat this study looking at quality of life questionnaires. And so, the questions I asked are very function based, right? Like, so do you go out in public and eat with your family or friends? Or are you able to untrained listener go up to somebody in a store? But, there's some very standard quality of life questionnaires. So I repeated that same study with a different group of patients. With looking at quality of life, and we very similar things, right? So in the nerve grafting group, patients had reported better swallowing. And so that to me has been very striking, and it's really kind of changed how we look at nerves for me and my team. And we are very, very quick to try to reattach nerves to try to see if we can get it going, which is not standard everywhere else. So what does this look like? Here's another case example for you. We're almost done with gross pictures. We have a few more slides and then we'll go. This is a lateral tongue cancer, so a growth on the side of the tongue here. Here's what it looks like when you take it out. And so you remove that whole cancer. Cancers grow with fingers, and so you got to make sure you cleared all the margins. And so this is what it looks like. Here's that index kind of picture I showed you where we take out the skin and fat from the forearm. We hook up a nerve with this. Here's the artery and vein. And then here's what it looks like at about 6 months afterwards. So you can see the tongue comes out well. And then it's neurotized. You can do this with other sites. So this is the lateral arm. So in patients who don't want their wrist operated on, whether it's a tattoo or a hobby like guitar players really use those tendons and fingers a lot. So I don't love using the wrist on a guitar player. You can use part of the lateral arm. You can use part of the parascapular flap, right? So that's that one we were talking about before. Here's that leg flap. And so there's all these different kind of sites you can use. And again, this decision obviously matters if you put nerves in, but it's a patient-centered decision to figure out where their best site would be to get them the optimal rehabilitation. So again, when we talk about these things, in brief summary, the donor site is important, and it starts the rehabilitation. People call it kind of prehabilitation in some other circles. We're probably getting there with head and neck, but it's not quite there yet. But counseling around the donor site and where we're going to pick it from. Early physical therapy, right? Survivorship has been a key part of my practice and our practice here at UPMC, the University of Pittsburgh. And then finally, again, if I can't stress it enough, and if I, every time I teach, residents and fellows and things, nerve rehabilitation is going to be an unbelievable part as we go forward to understand, how we take care of patients. So I'd be happy to take any questions and, appreciate the time that you guys took with me today.
Thank you, Dr. Spector, so much. Thanks for going into detail about all of the different ways that you and the entire department teams that we have established here work to kind of together get the best results for patients as they navigate their life, post cancer, post head and neck cancer. So we're thrilled to have you. I know you're already making a huge impact in patients. So we do have several questions. I'll go ahead and get started. First question about the recurrence rate of head and neck cancer. Is head and neck, type of cancer, are they more likely to recur? And how, if they do have a recurrence and you have to do surgery, like one of these reconstructive types of surgery, does that work like with respect to surgery if they have a recurrence?
That's a great question. You have to divide it up by subsites. We have two main populations of cancer that we treat. We have the HPV related cancers of the tongue base and the tonsil, and we have the smoking and alcohol related cancers of kind of the front of the tongue, the jaw, and the voice box. So if we take the first one, the HPV related cancers, the recurrence rate is very low. It can come back around the back of the throat. It can come back in lymph nodes. It can come back in the lungs. Those are for every cancer that we treat. It can always come back kind of where it started where it could spread to the lymph nodes and then in the lungs. It's easy to remember because we usually say it's like a third, a third, a third. A third come back locally, a third come back regionally, and a third come back distantly. So whenever your surgeon or oncology team is evaluating you, they should be doing a good head and neck exam to check the mouth and the throat, a good lymph node exam to check to make sure it's not back there. And then again, you should be getting chest imaging usually once a year is a very standard NCCN guideline. The recurrence rate is probably 15 to 20% in the HPV positive group, and it's about 40 to 50% in the other group. And so we're kind of winning the one game, right? Winning the HPV positive game, but the HPV negative game, we're still trying to make inroads on how to decrease the recurrence rates. Surgery after radiation, or when it comes back, or when, after treatment, is always harder. It's harder to get a good functional outcome because all the tissues have already had some type of treatment. And so it is a harder surgery. So I published a lot on salvage. We call it salvage after treatment or salvage cases. And the outcomes are not as good, but kind of setting that frame of reference and talking about all ahead of time can be really helpful to counsel your patients on what it would be like.
So in that same vein, can you discuss the complications that might occur for surgery after radiation therapy, radiation chemotherapy? Is it ever, the opposite, that you have surgery after a type of an intervention like chemoradiation, and also about proton therapy, if that is something you consider as well?
Yeah, for sure. Great questions. So rehabilitation and reconstruction that after radiation is always harder. There's no question. It's not that it can't be done, but what we underappreciate is the damage to everything that's around there that we're not trying to fix. So if you have had radiation to your throat and I'm fixing part of your tongue to swallow, I can make the perfect tongue, but the throat still got the radiation. It's still fibrotic. It still doesn't squeeze as well as it did before. Something called laryngeal elevation. So every time you swallow, throat goes up, larynx goes up, right? That actually decreases after radiation because this gets all fixed. You can have narrowing of the upper esophagus. And so, the swallowing and speaking is so multifaceted, like it's very, very hard to always predict what happens. And so that's why these salvage cases are so tough. And so exactly, so back to that question, very difficult after radiation therapy to predict what the whole problem is necessarily. Protons are interesting. So protons are a different type of radiation. So for those who don't know about it, usually we use photon radiation. So what happens is you can take 100 beams and you can aim them around at a target. So you have all these different beams, and this is called IMRT, intensely modulated radiation therapy. So you go into the machine, you have all these beams, and all the beams go through and cross. And so you can imagine you have all these different crossed beams, but where they target or where they cross, the dose gets escalated. And so the old radiation was 2 beams, 1 on each side, called conformal, and you got 1 hit here, 1 hit here. And where they crossed, you got the big dose, but your whole face got the whole dose all there. So if you're going to get, let's say, 70 gray, you get 35 from this side, 35 from this side. With 100 beams, your cheek may only get 1 gray, right? But it goes all the way through, and where they cross gets the 70. So that's a photon-based radiation. A proton-based radiation, you can actually control not just only the beam, but the depth of the beam. So you can take a proton and you can bring it in and you can stop it so you don't get the shine through on the other side. And so protons were thought to be the kind of the next generation of radiation. If you look at the data, there's no data showing protons are better. You can see early toxicity data. So during and after radiation, you do better with protons. There's less burns, there's less shine through, so you have a less mucositis. The side effects are better right away, but the long-term effects, not only the functional outcome, but the cancer outcome has not been shown. It's used mostly in skull base, where the dose to the brain doesn't like radiation, as you can imagine. Skin does okay, muscle does okay, but brain does not like it. So protons have been used more in and around the brain. But again, the long-term effects are not being seen. And you can only go to certain centers for protons. Protons are not everywhere around the country. There's, only maybe, I don't know, a few dozen, I would say, but, to get those.
Interesting. Thank you. That's something new that I learned, and maybe some of the rest of our audience as well. One more question about HPV, HPV related cancer. Is there like a gender breakdown that is significant between cancers in HPV? We talk a lot about HPV cancers and oropharyngeal cancers in this department, but as we know, it also causes a lot of other types of cancers and similar types of tissue. So I just wondered if head and neck cancer related to HPV had a gender breakdown.
Yeah, this is fascinating to me. And this could be a whole nother session. Maybe we need to open this up for another hour. The incidence of cancer in men to women for HPV positive cancers is 5-to-1 toward men. And so men are much more likely to have HPV-related tonsil and tongue-based cancer. And it's really hard to figure out why. Like, there's been a lot of questions on why that is. And there's some, there's a lot of thoughts. I'll give you the one that's kind of the leading thought, but I don't know that I believe it. It's that, the first time men are exposed to HPV is going to be in the tonsil or the tongue base. So that first exposure, that's where we think that the DNA and the host genome, like your first infection, could be where it is. But women can get cervical HPV, right? That's actually where we learned more about HPV-related cancers, was cervical cancer. And so there's this exposure that could happen at the cervix, right, to HPV. And if that's your first set of exposure, you may develop antibodies in your blood, right, to prevent you from getting further HPV infection or T cells or some type of immunity. And then if you ever get exposure in the tonsil or the tongue base, you already have antibodies or exposure risk there. And so your body knows how to deal with it. That's one kind of thought behind all this. I don't know if it's true or not. It could be just differences in immunity and how we deal with differences in immunity, but there's clearly a very high male predisposition for HPV positive cancers.
That's also really interesting, and maybe a topic for future discussions with, a panel, because there seems to be a lot of theories. One last question before I let you go. So we have patients now coming, especially with the addition of your team, you, Dr. Contrera, and then some of the fantastic surgeons we've had for many years here. But what do you see Pittsburgh offering to kind of the head and neck cancer community? Why did you come to Pittsburgh? Kind of, what are we offering patients and the world, like the research academic side in Pittsburgh, that you won't find anywhere else?
Yeah, I think we're certainly on the cutting edge of where we want to be. And so, Pittsburgh has always been a large research mecca for head and neck cancer and head and neck reconstruction. And with my joining the practice, they had a reconstructive component here when I got here, but we're expanding that out. And so whether it's 3D modeling, which I gave a talk on a couple of months ago about, or neuroadaptation or nerve grafting, or different donor sites, or really the conversation around how we take care of people. It's not a surgeon telling you, I need to take tissue from your leg to make this work. It's you telling me, these are my goals with, the types of reconstruction. And we have that joint discussion, I think, is one thing that sets us apart. And, we want to work with you to figure that out. And I think, as all my surgeons here have a very open mind about different donor sites, goals of patients, how we can rehabilitate. And then I walk into this, I already have a survivorship clinic here that I can send patients to that, and all the pieces of the puzzle are together. So I think all the pieces were there, but now we're just kind of bringing it together in a way that, really provides like a full kind of well-rounded care for our patients in Pittsburgh.
Well, that's great, and really exciting to continue to have these webinars on new topics and see how things develop over time. So thank you again. Thanks to our audience for spending this time with us today. As I mentioned, there will be a video, so after the fact, it should be uploaded in a couple of days on our website. So if this strikes a chord with you, please share it with family, friends, anyone who you think you might like to watch it. And we are always available to answer any questions you might have following today's talk. So with that, I'll let Dr. Spector go. I'll let our audience go. Enjoy what looks to be a very nice Friday outside.